All right, so here we are, Thursday, June 20th. My name is Dean. I'm with Sciatica Relief Now, and I am with Dr. David Hanscom, who's out in Oakland, California. He is a retired orthopedic spine specialist, correct?
Correct.
And I'm going to let him introduce himself. We're just going to talk a little bit, get some background on who he is, what he has done, and where he is now in his retired career, which is taking on a whole new meaning of its own, because it's hard to retire when you keep doing things. So,
Right.
Yes. Do you go by, what do you prefer to be called so I can call you correctly?
David's fine.
David. All right, David. Well, thanks for joining us. This is going to be put on the Sciatica and Piriformis Syndrome Relief Group page. We should be having some more people popping on here and there. But what we do is, I think I told you a little bit, I use a treatment technique called total motion release, where we look at parts of the body that are not painful, that are loose and comfortable. I always compare right side to left side, because what I try to let everybody in the group know is when the body has pain in it, and when the body senses pain, the body's natural response to it is to compensate. So I try to tell everybody, if you see somebody walking around on a sprained ankle, your body's lurching and jerking, trying to avoid the pain. And because of all the compensations, the body's out of its normal balance. There's increased, decreased tone, right side versus left, compared to normal. And what I do is I always compare right side to left side with different motions. And when I find a movement that's out of balance, I work the good side of it. Then we go back and check the bad side, and everybody's amazed that if something was tight, it is now looser. If something was painful, it's not as painful anymore. And then we go back and check their symptoms, and lo and behold, they seem to calm down as well. So those are the principles that I use, and I know you are now a master of pain science and figuring out that pain doesn't necessarily mean damage, and that pain has a lot of different components that may have nothing to do with what we as health professionals have thought for so long. So I'm going to turn it over to you, just sort of by way of introduction, sort of give a little bit of your background, how you've come to where you are now and not doing surgeries, and what you have found along the way. So David, I'm going to turn it over to you, and thanks again for joining us.
Yeah, thanks, Dean. I appreciate being here. I always enjoy these conversations. And just to give a little background, I was trained in a very traditional manner. I went to Loma University. I did two years of internal medicine. I did orthopedics at the University of Hawaii for 3 years. Then I trained in a high-level spine deformity fellowship, which was one of the top fellowships in the world at the time. And I came to Seattle in 1986, really on fire to do surgery. I was trained well. I was taught that surgery was the answer. If everything else had been tried, then let's try surgery. And for 8 years, I actually was one of those super aggressive surgeons. Seattle had 9 times the rate of spine surgery per capita as any place in the country at that point in time. Wow. I was one of those people. But what the deal was is that we had a new instrumentation called Steffi plates, where we put screws directly into the spine to stabilize it. It enabled us to obtain a solid fusion a higher percent of the time. So what happened is that we thought we had the answer. We're getting solid fusions. And then there's also a test called a discogram at the time, where we inject a dye into a disc. A radiologist would do this. If the dye was pressurized and a certain volume measured, if that standardized volume and pressure created the patient's usual pain, then it was assumed that that disc was the source of the pain, and we would do a fusion. And I did that aggressively for about 7 or 8 years. I talked to my radiologist, or I ordered the discography. I did lots of surgeries, but my results weren't that great. And I was starting to get a lot of questions about it. So I started asking people, well, what's the data? And they're going, well, we don't know. Then in 1993, a research paper came out showing that the success rate in the state of Washington in a workers' comp patient was 15%, 15% at 1 year follow-up, and 22% success rate at 2 year follow-up. So I just stopped. I go, because I honestly thought that the success rate of a spine fusion for back pain is around 90%. Otherwise, why would you want to go through this big of a definitive operation? Then the data became apparent, that's been there for decades, that disc degeneration, bone spurs, bulging disc, herniated disc, none of those have anything to do with back pain. They've actually been proven to not be a cause of back pain. So I just stopped. I didn't have any idea what to do. If a person came in with back pain, I would just do the best I could and maybe order some injections and physical therapy. But a lot of people, of course, weren't getting better. At the same time, for about 15 years, I went into my own chronic pain syndrome myself. I developed extreme chronic pain for about 15 years, with the last 7 of those being absolutely intolerable. I came out of it by accident in 2003, and I didn't really figure out really what was going on to around 2010, 2011, where the neuroscience researchers actually showed us the nature of chronic pain. And although an injury, for instance, a back injury, can start the process, what happens is that your brain memorizes the pain impulse just like an athlete or an artist or a musician learning a skill. And this pain gets memorized quickly because the impulses come in so quickly. It turns out that chronic pain is a programming problem. The definition of chronic pain by the neuroscience literature right now is that it is an embedded memory that becomes connected with more and more life experiences, then the memory can't be erased. Then a very definitive paper came out in 2014 out of Chicago that looked at a group of patients who had back pain for less than 3 months. They did what's called a functional Mri Scan, which measures brain activity in certain regions of the brain. And of course, in every patient with acute low back pain, the pain center lit up, as you would expect. It's called the nociceptive center. Then they took people that had chronic back pain for more than 10 years. None of them had the nociceptive center active. The pain was only in the emotional center. In other words, what happened is that the acute pain would die down, but by then the brain had memorized it. The definition is that the pain gets connected with more and more life experiences, and the memory can't be erased. So what happens is that this pain is associated with getting out of the car, getting out of bed, climbing stairs, etc. So your brain links things all the time. So as that pain is constant, becomes more and more connected with your life, it becomes very, very embedded in your nervous system. Then they took the group of patients with acute back pain. They did scans on them every 3 months. Then they find out that half the group went to pain-free and half the group went on to chronic pain. And the patients who went pain-free, the pain center dropped down as you would expect. And the ones that became chronic, every one of them went to the emotional center, and the pain center dropped down to 0. So it's a very clear anatomical study that showed that the brain activity simply changes over time with chronic pain. So you have an acute back injury, which hurts a lot. I've had 2 back surgeries myself. And then by the time the pain resolves, for a certain number of people, that pain gets memorized by the brain. Then you have a neurological issue as well as inflammatory issues, et cetera. Anyway, long story short, I started sharing these ideas with my patients in 2011. I wrote a book called Back in Control, A Surgeon's Roadmap Out of Chronic Pain. And it's not just back pain, it's anxiety, it's depression, it's PTSD, it's fibromyalgia, burning sensations, irritable bowel, spastic bladder. So when you're trapped by pain, your body chemistry is way off, which affects every organ. And there's over 30 symptoms of an adrenalized, stressed out nervous system. When I was in the worst part of my chronic pain, I had 17 of these at the same time. They're all gone. So anyway, the process evolved in an interesting way. I have no idea what I was talking to you about unless I'd gone through a pretty horrible experience myself.
Wow. I am not familiar with all that data, but I know Manya actually got your book and is halfway through it by now. But seeing how most of these people here are dealing with back pain, I know some are actually on other sites and they're asking about the success rate of surgeries and everything else because they have herniated discs. I won't mention any names, Jesse. But what would you say now, knowing what you know from pain science, knowing what you know from your back surgical history, when is somebody who has low back pain with definitive scan results that show whether bulge or herniation, when would you say that a low back pain client is appropriate for surgery? What kind of...
Never. Yeah. So that's what's ironic about modern medicine. And I talked to a guy on my podcast from Australia, Ian Harris, who wrote a book called Surgery, the Ultimate Placebo. And what's ironic is that back pain is the most common cause of disability, right?
Yes.
We only know where it comes from exactly about 5% of the time when the spine is grossly unstable or a tumor or infection. It's been definitively proving that disc degeneration, bulging disc, arthritis, herniated disc, collapsed disc, bone-on-bone disc, those have been demonstrated to not be a source of pain absolutely been shown not to be a source of pain. So now you have something that has disc degeneration, which I call, it's not degenerative disc disease, it's simply a normally aging disc. No question the spine is stiffer, but there's nothing that says that the degenerated, actually more stable disc is a source of pain. Then remember the brain actually memorizes the impulses, right? So you get the injury, which is usually muscular in nature. Maybe the disc itself starts it, but then the brain memorizes the pain. Again, the success rate of a back fusion for back pain is about 22%. And the data also shows that if you operate in the presence of a fired up nervous system, which happens in chronic pain, you can actually induce pain or make it worse 40% of the time. You have about double the chance of making it worse than you do of actually solving it. It turns out that, I mean, I don't know anybody that would really want to go through an operation of that magnitude. By the way, it has a 20% reoperation rate within the 12 months because of complications. So you have almost the same reoperation rate as you do success rate.
So the odds are not good. So how would you counsel? I know I have many people in my group who have the herniated disc. It shows it on the MRI. Actually, right before this, I went on to another group because I saw that somebody from my group was posting in another group. I mean, it shows a definitive bulge into the spinal cord, a nice little bulge. She's asking for people, which I don't understand why people go on to Facebook and ask others what they see and what they would do, because there's it's mind-boggling.
It's a bad idea.
It's a bad idea.
Bad idea.
That's why I started my page, and that's why I said, look, if you're going to post a scan, I'm going to take it down, because there's nobody here, number one, who's a radiologist who this is what they do, and number two, even if you see something abnormal on it, that doesn't mean that that's the source of anything. And I have stats to show them, but obviously when somebody's in pain and they go to the doctor and they say, you know what, wow, you've got a herniated L4, L5 disc, it's pushing into the thecal sac, it's pushing into here, that's the source of your pain. How would you talk to them? How would you counsel them to say, okay, let's look at something that may not make sense to you right now, but let's consider other things other than that disc causing the pain?
Right. So are you talking about back pain or leg pain now?
Let's talk about leg pain, because that's typically what most people in the group have. They have the searing pain down the sciatic nerve distribution.
Okay. So I just want to finish the discussion on the back pain, just to be clear. Back pain is nonspecific. It can come from muscles, tendons, ligaments, the facet joints, ligament and flavum. There's a bunch of structures in the spine that can be painful, including the disc. The problem is there's 5 discs in the lumbar spine. How do you know which one is actually the painful disc? There's usually bone spurs on all of the discs. We do know that multiple level fusions have less success than single level fusions. And to turn your spine into a solid piece of bone, scar tissue, and steel rods makes no sense. So a lot of us think it's actually akin to doing a frontal lobotomy. It's an operation that should probably never be done. There's not one research paper that documents that a back fusion works for back pain. Not one. 0. But right now it's over a $10 billion a year industry, but there's no data that says that it works. And again, the data says that the people are operating on degenerated disc. There's actually at our institution in Seattle, actually University of Washington also, where they now have every radiology report says disc degeneration is considered a normal finding of age. It should not be considered a source of pain. It's on every radiology report now.
That's awesome.
It hasn't slowed the surgeons down. Now, leg pain's a different deal. Is that, first of all, leg pain can be from tendonitis, the iliotibial band, or perineal tendonitis, or different tendinitises. Sometimes people have a ruptured L3 disc, that looks like patellar, condylar patella, pain behind the kneecap, or it can be pain behind the kneecap. So remember, pain down the leg is just a symptom. And there's multiple causes. You can have a ganglion cyst in the sciatic nerve. I've seen one chondrosarcoma of the sciatic notch. I've seen a couple bladder tumors pushing on the femoral nerve. So it's just a symptom, number one. Second of all, if there is a bone spur or a disc pinching the actual nerve in the spine, and the nerve is painful in that distribution, that is what defines a structural problem. In other words, you have a pinched nerve, the symptoms match, that's a structural problem. And I'm not against spine surgery. I mean, I was a busy spine surgeon until the end. But what we found out is somebody has a structural problem that when you do surgery, it works most of the time. And the metaphor I like to use is going to the dentist with a painful tooth. If you pull the tooth, it works. If you go to the dentist with mouth pain, but you don't know where the pain's coming from, you start doing procedures, it's not going to work, right?
Right.
I define a structural problem as an identifiable anatomical problem with a matching symptom. And surgery in that circumstance works really well, except in the presence of chronic pain. So in other words, the data also shows if you have chronic neck pain and, for instance, have a hernia repair, you can induce chronic pain at the hernia site up to 40% of the time. 5 to 10% of the time, it can become permanent. Nobody discusses chronic pain as a complication of surgery. So what happens with chronic pain, again, you have these memorized circuits, your brain's already lit up, you start plugging in body parts. But what the data does tell us to do is that for every elective surgery that I did the last 5 years, maybe 6 years, is that we would go through the risk factors that actually affected outcomes. So we would systematically, number one, address sleep. We would teach people about the nature of pain. We would adjust medications. We'd do appropriate physical therapy like you just described. We would just look at their general life outlook, and we'll talk about body chemistry in a second. But if you're angry and frustrated, which chronic pain tends to make you pretty frustrated, by changing your body's chemistry, it doubles the nerve conduction and you feel the pain more. So just calming people down was part of the prehab process. So we called it prehab, which is rehab before surgery. We did that for 8 to 12 weeks for every patient we did surgery on, and the results were spectacular. But that's what the data says to do. But the data also shows, there's a paper out of Baltimore in 2014 that shows only 10% of spine surgeons are actually acknowledging and addressing the risk factors that affect outcomes. 10%. That's why I actually quit spine surgery, by the way, because 3 to 5 times every week, I see people come in with basically normal spines. And what's happening with improved technology in spine surgery is that they're actually throwing bigger operations at smaller problems. And the problem is we can do them. We have the technical skills to do them now. The problem is a bigger operation is more trauma on your body, much higher complication rate. And 3 to 5 times every week, I see people come in with bigger operations either performed or recommended on normal spines. And then the devastation of a failed back surgery is just beyond words. It's unbelievable. And I get it. You've been bouncing around. So it's not necessarily the patient's fault. You know, patients are accused of just wanting a fix. And who wouldn't? I mean, everybody wants a fix. But the medical profession has the data right there in front of them. We actually know the answer to chronic pain, which we'll talk about in a second. We are absolutely categorically ignoring the data. Essentially, every treatment we offer in spine care has been documented to not be effective. So we're literally pretending to offer medical care, and you get your hopes up, you have them dashed. The animal studies show that one way to induce depression is repeatedly dashing hopes. And that's what we're doing. We're pretending to offer a solution. We actually know from research data that it doesn't work. We do it anyway. And even if you don't have a complication, you have another level of hope taken away. And really what we're doing right now is unconscionable in spine surgery. That's why I quit. I just hit a threshold. I just said, I can't watch this anymore. I quit my practice at the peak of my career, actually to pursue this full time. I don't know exactly what I can do to change the face of medicine, but I'm going to do what I can do in my own sphere. But no, watching people go under the knife unnecessarily every week is just brutal. Then we can talk a little bit later about the complications I would see from, it's bad enough to have a complication from an indicated surgery. It's just really completely unacceptable to have a complication from a surgery that you didn't need.
Oh, absolutely. Wow, my mind is already blown my mind, and I think I'm losing out on questions that I can even ask you about it. But I know one of the things we wanted to get to was the stress and anxiety and how that plays into pain, and you have already talked a little bit about it. But what would you say to people, because this is where many people in my group are at. They're doing my exercise, they do find some relief, and people are getting better, which is awesome. But there's those people out there who maybe not doing the exercise or have not yet met with me, but they're getting these burning pains, and I see them on the disc problem, chronic disc problems, or
Excuse me.
No problem. Microdiscectomy groups, and all these people on the microdiscectomy group say, hey, I woke up, my leg pain was gone, I feel amazing, blah, blah, blah. And it appears that these people are getting the help that others want, because when they remove that disc in a microdiscectomy, and correct me if I'm wrong, when they do a microdiscectomy, they don't plug the hole where the disc comes out of, do they?
Right.
So what's the thinking behind it? What's the thinking behind a surgeon's perspective of all you need to do is bend forward, get a little bit of that nucleus pulposus to leak back out, and you're herniated again? What stops another leakage or herniation?
Nothing. That's the one problem with microdiscectomies. First of all, they work. I mean, that is a structural problem. You have a pinched nerve. Let's say you have a ruptured L4-5 disc that hits the fifth nerve, which goes down the side of the leg, right? If you take the pressure off that fifth nerve, the pain down the side of the leg is going to disappear. But remember, the back pain's not going away. You can get rid of the buttocks and leg pain, but your back surgery does not get rid of back pain, period. Okay. Now, the back pain and the leg pain are solvable with rehab that we'll talk about in a second. The problem is it's not possible to fill the hole up. You reach in and you pull material out as much as you can that's loose. And the re-rupture rate's about 10% within 10 years, is about 1% per year. And my re-rupture rate was lower than that only because I was so hyper about posture and body mechanics. In other words, if you keep your back straight, lift with your legs, twist correctly, etc., the chance of re-rupture goes down dramatically. Preventing re-rupture is a rehab issue. There's nothing you can do at surgery to plug that hole.
Okay, that's what I thought. Yeah, when I tell that to people, it reminded me of when I was first out of school. We had a ankle surgeon who came in who was known in the Phoenix area for doing ankle reconstruction surgeries for people who have repetitively sprained ankles. And halfway through, he said, well, what we find in surgery is that at least 3/4 of the tendon or 3/4 of the ligament, the anterior talofibular ligament, is torn. So what we do is we cut it and then we reattach it.
Okay.
And he said that, and I went, hold on a second. You mean to tell me you cut the ligament that you're trying to repair, you cut it and then you reattach it? He said, yeah. I said, I am not a rocket scientist, but is that like going into somebody's rotator cuff saying, hey, you know what, you've got shoulder pain, let's cut your rotator cuff tendon and then reattach it and repair it? He said, well, it's not the same because they're having a problem in their ankle. I go, well, if somebody has a problem in their shoulder, can't you just, I said, it just doesn't make sense to me why you would cut it and then reattach it instead of trying to strengthen the muscles around it so you don't have to cut it in the first place. He said, well, you really don't understand. And I said, well, please enlighten me, because I wasn't questioning whether he should be doing that or not. I was just trying to wrap my head around the fact that you're going in to repair something, and in order to repair it, you've got to cut it and injure it to repair it. So that's maybe.
Yeah, it's probably not the best analogy for the spine. I mean, I honestly don't know the answer to that question. I used to do ankle surgery myself since I'm an orthopedic surgeon, but it's part of it. Could be a semantics issue type thing.
Okay.
So let's go to the pain part of it, how the stress makes a difference in your pain.
Absolutely.
So I want to just take 5 minutes and just give a little bit of we talked about this a couple of days ago, is that the way the body works is that you have a nervous system that interprets sensory input, and it causes you to automatically act in a way that keeps you safe. It's called the nociceptive system. So bright lights, loud sounds, hot pavement, etc. You avoid all those instinctively, but you don't think about it. You don't automatically look away. You don't consciously not look at the sun. Your brain automatically directs your eyes away from the sun, right? And so your unconscious brain processes about 11 million bits of information per second, with the highest concentration being in the eyes. And pain is one of those senses, of course, that keeps you in a safe zone, right? But any part of the body that has an extra threat to it, your body says danger. What you're doing, if you have a physical threat, your body says this is a threat. You have it go to the central part of your brain that secretes stress chemicals, adrenaline, cortisol, and histamines. And then your body takes action to avoid the threat. Problem solved. Anxiety drops. Anxiety is just the sensation generated by the stress chemicals. That's it. It is not a psychological issue. When your anxiety is elevated, your stress chemicals are up. The problem is that when humans have a major problem called the curse of consciousness is that thoughts, unpleasant thoughts, go to the same part of the brain, same chemical reaction. The problem that humans have is that you can't escape your thoughts. So you have these elevated levels of stress chemicals, you feel anxious, and since you can't escape your thoughts, you're trapped. Then your body secretes more stress chemicals in an effort to escape. You become angry. Turns out that anxiety and anger are the same thing, but they're just descriptors. It's just like a barometer tells you how your stress chemicals are. If you're on the beach laying in the sun and full of oxytocin, dopamine, serotonin, the relaxation drugs, you feel relaxed, right? But you wouldn't call relaxed a disease or a diagnosis, correct?
Correct.
And therefore, same thing with anxiety. It's not a disease or a diagnosis. It's just a word that describes the level of your stress chemicals. The way you decrease anxiety is you decrease the stress chemicals. If you want to talk about it and try to fix it, you actually crank up the problem, make the stress chemicals worse. Every human being has to deal with anxiety. In other words, the sensation generated by those stress chemicals is intended to be so unpleasant it forces you to take action to solve the problem. It turns out that relentless anxiety is the essence of chronic pain. Turns out anxiety is the pain, because if you look at the sun for too long a period of time, you become anxious and you want to look away. If somehow you're trapped looking at a bright light that you don't want to look at, you become incredibly anxious, then angry, right? To try to solve the problem. It's the same thing with your thoughts. None of us can escape our thoughts. So what happens when you're trapped, so again, medicine's called anxiety a psychological issue. This unconscious brain is processing 11 million bits of information per second. The conscious brain is processing 40. You're not going to solve anxiety by pitting your rational brain against the unconscious survival response. Can't do it. So what happens, you have sustained chemical assault, then you're trapped by the pain, which is very unpleasant. What happens is that each organ is now bathed in an unpleasant chemical bath. So it affects the blood supply to the brain, bowel, and bladder. So you have migraine headaches, you have spastic bladder, irritable bowel. You have nerve conduction increasing, so you have burning sensations around your body, tinnitus, ringing in the ears, but also increased pain because you've doubled the nerve conduction, you're on high alert, your whole body is sensitized to danger, you feel the pain more. In other words, you've changed the pain threshold. When it comes to pain down the leg, let's say even if there is a bone spur, you first of all have to decide whether the pain is severe enough to warrant going through surgery. What we found out over the last 5 years is we went through this prehab process and literally calmed down people's nervous system, calmed down the adrenaline and cortisol. The pain threshold would change. They would cancel the surgery because the pain disappeared. And so so it actually doesn't really matter where the pain arises, whether it's a bone spur or just a lit up nerve from a virus or whatever it is. The prehab is really critical because we found out even with a structural problem with leg pain, if we jump right in and do the surgery right away, it probably will work. But if it doesn't work, a lot of times people are worse. So by decreasing the body's stress chemicals, you've improved the nerve conduction. This has nothing to do with psychology. It's just threat, chemical reaction, response. It's a survival response, and you're going to feel more pain. Again, the way you decrease anxiety is you decrease the stress chemicals. The essence of what I call the DOC Project, I wrote a book called Back in Control, A Surgeon's Roadmap Out of Chronic Pain, the goal of the book is basically to learn to auto-regulate your body's chemistry. And you can't escape your thoughts, but there's things you can do to modify the whole process so you don't have that huge adrenaline response all the time. There's 4 stages on the website. Stage 1 has a simple tools like expressive writing, relaxation, not discussing your pain, etc. And it's beyond the scope of this discussion to talk about that. Now, I'd be happy to talk about this on a future podcast, but the good news about the project, between the book and the website, it's about 90% self-directed. It doesn't, whether it's back pain, leg pain, headaches, whatever it is. I had 17 of these symptoms at the same time. They're all gone. I had ringing in my ears for 25 years. It is a miserable, miserable symptom. I thought I had it the rest of my life. It's gone. But my nerve conduction's improved so that sensation of this ringing it's now, I'm now below that threshold, right?
Okay.
So again, there's over 30 symptoms created by a stressed nervous system. And then the two ways you decrease anxiety or decrease the stress chemicals is directly through mindfulness relaxation techniques or neuroplasticity, where you just calm down the whole nervous system and actually cause your brain to be less reactive. You literally rewire your nervous system to be less reactive and drop the stress chemicals that way. So it's been a remarkably consistent process. We've watched hundreds and hundreds of patients go to pain-free. Chronic pain is a complex process. You have to treat every aspect at the same time to solve the problem. It turns out everything works a little bit in chronic pain. Nothing works by itself.
What would you say of everything that works? I mean, I know you said it all works together, nothing works by itself, but what would you say calming the anxious thoughts would be the first and biggest step that people can do?
Can't do it.
Okay.
So it's called, so again, the way you decrease anxiety is you decrease the stress chemicals, right?
Yes.
So the process of neuroplasticity is awareness, separation, and reprogramming. So by trying to do battle with the thoughts and calm them down, you're actually going to lose that battle, right? So what cognitive behavioral therapy does is you look at the maladaptive thought pattern, where this person doesn't like me, then answer the telephone, whatever it is that keeps spinning away in your brain. I'm not good enough. I should be doing this, etc. So you look at the cognitive distortion. So it's awareness, separation, reprogramming. So you look at the disruptive thought, you create a little bit of a space by writing it down, and then you substitute a new thought. And so with repetition, you actually start changing the physical structure of your brain, because we know the brain changes every second. It's called neuroplasticity. So yeah, looking at thought patterns is one thing. But again, it's awareness, separation, reprogramming. The easiest and hardest part of this process, and by the way, it's not very hard. Essentially, none of these patients that have gone to pain-free have seen a psychologist, even though I think they're very helpful, is that you have to allow yourself to be able to feel anxious before you can actually change direction, right? So it's awareness, separation, reprogramming. What most people do, including myself historically, I was a master of suppressing anxiety. Most people suppress anxiety, they don't feel it, then you can't redirect. So it's a learned skill. Remember, anxiety is just a measure of your body's stress chemicals. So if for some reason I'm a little bit anxious and wired, I can just drop my shoulders a little bit and relax a little bit. That decreases the stress chemicals. That decreases the anxiety, right? So again, so by talking about your problems incessantly with really trying to understand it, you actually put your attention on those thoughts and actually make it worse.
Okay.
So as far as ways, so again, there's two ways to decrease the stress chemicals, and they're both important. One is directly, you talked about active meditation. You just drop your shoulders for a second and take a deep breath. So about 3 to 5 seconds, you just feel your shoulders. And so what you're doing, you're switching sensory input from thoughts to a different physical sensation. I call it active meditation. That just directly drops down the adrenaline right there. But the other way, the neuroplasticity, is that there's an exercise called expressive writing. And I think I showed you this book. Dr. Penny Baker, Dr. Smythe, and Dr. Wegner, for years, have done research on what's called expressive writing. There's over 1,000 research papers that simply you start writing down your feelings and just tearing them up. It can be positive or negative, and I do it every day. It was the one factor in my entire life, after 15 years of searching for every answer you can imagine, that I actually found the answer to the chronic pain was that expressive writing. We don't know why it works, but over 1,000 research papers that says that it works. Again, on stage 1 on my website is stage 1, step 2, talks about expressive writing, explains why it works. Sleep is a big deal. We found out that lack of sleep actually causes chronic pain. They did a study out of Israel showing, it's a 4-year study on over 1,000 patients. They found that lack of sleep actually caused back pain. It wasn't the other way around. And so they actually looked at both directions. They found that back pain didn't cause lack of sleep, but lack of sleep actually caused back pain. The other concept that's been really powerful as far as a starting point is that we realize that your brain's going to develop wherever you place its attention. Remember, with neuroplasticity, you're literally trying to direct your brain. You can't control your brain, but you can direct it. And so one of the cardinal rules we have is that when a patient leaves my office, I say, look, you will never discuss your pain the rest of your life, ever, with anybody except your providers. Your colleagues, your family, your friends, you don't discuss your pain. That's what the piece of paper is for. Just write it down, tear it up. So the expressive writing, people tear it up right away for two reasons. One is to write with freedom. You can't control your thoughts, but you can separate from your thoughts. So the reason to tear up the writing immediately is to not analyze them. Because you want to analyze these, quote, issues, your attention's on the issues. From a neuroplasticity standpoint, we're actually reinforcing those thought patterns. So you can't control your thoughts, but you can separate from them. It turns out that anxiety actually is the pain. If I give people a choice to get rid of their leg pain or their anxiety, the vast majority of people want to get rid of their anxiety.
Interesting.
Yeah. So it's the mental pain is actually the bigger problem than the physical pain because it's, first of all, progressive. It gets worse as you get older. It gets like an athlete learning a skill, and you can't escape it. And I have some arthritis in my hips and knees now, which is probably more painful when I had my own chronic pain, but I don't have this crippling anxiety anymore. So it's just pain. I couldn't deal with the relentless anxiety. It was brutal.
Interesting. Are you relating to this, Manya? Just, you can nod your head yes or no. Jesse, yes. Jesse's the one who's got, who's trying to avoid surgery at all costs, which he will because he's learning something good today. And Tina, can you hear me? Is this relating? Are you able to relate?
Yes.
Okay. All that anxiety?
Yeah, definitely.
Okay, good.
The thing is so I give entire podcasts in this, but I just want to leave everybody one message. First of all, surgery only works if you can see the cause of the problem. And if you take a car to a shop and start randomly replacing parts, it doesn't make any sense. So if surgery is only indicated if you actually can see the problem, then even then you can often avoid surgery. So to me, I say, I'm just pretending you're my patient, Jesse. I say, look, if you're in my office, my goal is to get you better with or without surgery. It doesn't really matter to me. We're going to optimize your chance for success. We're going to calm down your nervous system and help you move forward. But the bonus is people's anxiety drops dramatically. And what happens once you look at anxiety, it's just a measure of your stress chemicals. You get to depersonalize it. In other words, it's just, okay, I'm anxious. My stress chemicals are here. And if you want to get onto these life issues and other issues creating the anxiety, it just doesn't work. So you develop your own toolkit, literally your own personal toolkit to just start calming yourself down. Everybody does this completely differently. The book to me is basically a framework that allows people to find their own solutions. The three parts of solving chronic pain is simply understanding the problem. And again, the mental pain is a bigger problem than the physical pain. Second part, you treat it like a forest fire. We treat every aspect simultaneously. The third part, which is most critical, since every person is unique, you have to take charge of your own care. And it's not very hard. And again, I like pain psychologists. There's not many around. Out of over probably 1,000 people that have gone to pain-free, including decreased anxiety or especially decreased anxiety, maybe 15 of them have seen a psychiatrist or psychologist. So this expressive writing, for whatever reason, again, Dr. Pennybaker, who started the research, is a psychologist, so is Dr. Smythe. And I asked him, a few weeks ago, why does it work? We go, we don't know. But there's hundreds and hundreds of research papers that says this expressive writing somehow drops blood pressure, improves asthma, improves rheumatoid arthritis. It actually doubles skin healing on volunteers' punch biopsies. And then anxiety, depression, all these other things improve dramatically. But the benefits of the simple tool called expressive writing are unbelievable. And what I'm frustrated with as a physician is that this data has been around for a long time. There wasn't any point in my training I learned about the benefits of expressive writing, never was presented. I ran across the data. I actually started the process myself before I knew there's so much data behind it, sort of by accident, but it's never taught to us. And then you look at spine surgery, like I said before, there's not one research paper that documents that spine surgery works, not one. So you get 1,000 papers putting out a tool that has no risk to it. I mean, if you're sitting there as an audience, just write down, I just wrote before I started the podcast, sort of a wired day, I'm just calm myself down a little bit. So just write down some thoughts, tear it up. How hard is that to do?
So really, so expressive writing in a nutshell, just write down your thoughts and emotions on a piece of paper.
Tear them up.
Tear it up.
Yep, and just random. Some people just doodle and all of a sudden a word comes up. Some people make a list. Some people just draw circles. There's something about, I mean, if you think about this, taking a thought and converting it into a motor function occupies a large part of the brain. It's a complex process to take a thought and turn that into a motor function. But there's something about those writing exercises that disrupt that whole set of these circuits that are so crazy. And the other thing is that you can do it verbally. You can just sit in a quiet room by yourself and simply verbalize your thoughts. I used to do it in the car, except I think it's just a little risky, honestly. So I'm not recommending that. But yeah, you just convert anytime in a quiet spot. David Burns, in his book Feeling Good, made a recommendation, which was very powerful for me when I was going through the worst part of my own chronic pain, is simply standing in front of a bathroom mirror or in front of a mirror and talking to the person in the mirror with the voices that you talk to yourself with. And it's not rational, not logical. You never would talk to another human being the way you talk to yourself, right? But that's also an exercise that's very powerful, is you're sometimes externalizing these thoughts. And again, you can't control them, but you can externalize them. And by separating from this, so you have to allow yourself to feel them, express them, then you redirect. Because remember, the process is awareness, separation, and redirecting. The writing does the awareness and separation in one move. And then redirection is low active meditation, good food, good wine, good friends, exercise, which you do. But to get to these other tools being effective requires you allowing yourself to actually be aware of what's going on in the first place. So awareness is the key to this whole process. Okay.
Fascinating stuff. And I will be ordering your book because I do need to read this stuff, because obviously I deal with people on a daily basis who are crying for surgery, and I'm going, look, I try to let them know what the research shows, but they're like, oh, but you don't understand the pain. I'm going, you know what? I know I don't, but I know that what you're heading into is not the answer, and you may find immediate relief of your leg pain, but eventually it's going to catch up with you. So Jesse did just type in and ask, I don't know where he popped off to. He was looked like a barbershop. Did he say earlier that microdiscectomy does work for leg pain, but leads to more issues afterwards? And I'll let you know.
I think the data shows pretty clearly that a microdiscectomy is a good operation. The key issue is your pain sort of a nuisance? Is it just numbness and tingling? So I don't think mild pain or numbness and tingling are indications to go through the risk of surgery. I mean, I've seen people die from a microdiscectomy because the surgeon reached through the disc and actually got the aorta. So anything can happen with any surgery anytime. Okay. So if the pain is moderate to severe, really interferes with his lifestyle, and he's done the prehab, that's the key issue. Are you sleeping okay? If it requires medications to sleep, use the medications. So sleep's number one. Are you doing the writing relaxation exercises? Are you learning how to regulate your body's chemistry? There's a high chance that pain will go away without the surgery. I just talked to a friend of mine who went to one of my workshops, and he had 2 years of really severe leg pain. He's also under a tremendous amount of stress at the time. And after he did my workshop, he was able to see the link really clearly between stress and his pain. So in days that were better, his leg pain was reasonably tolerable. In days that were really bad, his leg pain was through the roof. He sent me his scans years ago, and it was sort of a marginal call whether surgery would or wouldn't work. And I really gravitated towards not doing surgery. It wasn't that compelling of a problem. And I just talked to him this morning, and he's fine, been doing fine. But again, if he gets stressed out, that pain pathway is still there. It'll kick up. But so it's all relative. So people think you get a microdiscectomy, your spine is fixed. It does fix the leg pain. It does take the pressure off the nerve. But as you pointed out, you still have a hole in the disc, right? You don't have a normal spine.
And Manya just asked, and I'll answer yes. So this technique will work not only for pain, but migraines and other issues. And absolutely, he actually mentioned migraines earlier. So anytime you decrease the stress and the anxiety, any physical ailment actually will minimize.
But again, I'll just say it again, is that it's not psychological. In other words, you have a threat that translates into unpleasant chemical environment. Well, I would say unpleasant. I mean, it's a necessary protective chemical environment that translates into physical symptoms. So for instance, with migraines, we know that adrenaline decreases the blood supply to the brain. Then I had migraines my entire life, which are now gone, thank God. I had the real deal. They started when I was 5 years old. But what happens is they will always happen on a Saturday when I was starting to relax. And what I now know is that adrenaline decreases the blood supply to the brain. When you relax, of course, the blood vessels will now dilate, and bam, just a pounding severe migraine. Those are gone. But there's if you look on the website or in the book, there's a list of over 30 different symptoms that respond to the more optimum chemical environment.
That's awesome.
Tinnitus is a big one. I mean, a lot of people have tinnitus, and it seems like not a big deal, but it is horribly annoying. It's horrible. My feet since 1980. Again, in retrospect, I was in the middle of my residency, lots of stress at that point. My feet started to burn, and I thought it was just a hot pavement in Hawaii when I was running. It just kept getting worse and worse and worse. That symptom's gone. Now, if I quit using the tools that I teach my clients, then in about 2 weeks, my symptoms come back. So my feet start to burn. These little skin rashes pop up on the backs of my wrist. My scalp starts to itch. My ears start to ring. I quit sleeping as well. Anxiety goes up. So I finally decided to quit doing this expressive writing on a reactive basis, but just be more proactive, just consistently doing the tools in a proactive way, just to make my life better. But the other thing that's incredibly exciting to me, the data shows only 20% of physicians are comfortable managing chronic pain, less than 1% enjoy it. And again, the reason we're not trained to do it, but when I get to work with people that are just stuck in pain, have no hope, buffeted by anxiety, when they come out of that hole, it is unbelievably inspiring. It's by far and away the most rewarding phase of my career. It's unbelievable. In this workshop we do every year, again, this year happened again, 80 to 90% of the people in the workshop go to pain-free within the weekend. But what happens, we go from your usual pain world to a very safe, structured environment, and people relax. As you relax, it changes the body chemistry from stress chemicals to play chemicals, completely changes the game as far as your perception of pain.
Wow. That is incredible.
It's been remarkable. I mean, for me, I'm a surgeon. I still think like a surgeon. And so every time somebody walks in pain-free, I just go, what? I mean, still a part of me that has a hard time believing this whole thing. But
right.
Again, my own experience, like 2 days ago, I was as relaxed as they've ever been. My knees and hips felt fine, felt good. Then I got a little bit triggered yesterday. Guess what? I hurt. Neurons that fire together, wire together. But again, not psychological. It's just a linkage system.
That is great to know, because so many people, I used to tell people jokingly, they say, are you telling me my pain's in my head? I go, well, put it this way, if I cut your head off, you wouldn't have the pain. And they go, that's not funny. I go, but it's the truth, because this is where it's all coming from. I said, I'm not saying it's all happening in there, but that's where it's all being read. So yes, it is coming from your head, but not in a, like you say, it's not a cycle. You're not a mental case here. This is not something that's abnormal.
Well, let me just put a metaphor out there. I think that's very helpful, is that, a Boeing 747 jet flies with a computer taking in sensory input, right? It's taking in altitude, fuel, whatever it is, wind speed. So it's taking all that data in and analyzing it and flying the plane. How well do you think that Boeing jet would fly without a computer? Not possible. Okay, the human body could be at least 8 trillion times more complicated than a Boeing jet, at least. So how would your body function without a nervous system? And how would your nervous system function without the body, right? So it's really a unit. So the concept of mind versus body is an incredible misnomer. It's your nervous system that keeps you alive. The conscious brain is only about 70,000 years old in the course of human evolution. And again, your conscious brain is processing 40 bits of information per second. Your unconscious brain is processing 11 million bits of information per second. And when I put my hand on this table, the reason why this table isn't hot is because my brain says it's not hot. The reason why this chair is a chair is because my brain says it's a chair. There is there's no inherent property of a sensor that says this is a chair or a table or painful or comfortable. 100% of everything is interpreted by your brain.
Very true.
So even the idea of the pain is in your head, I mean, if you didn't have pain sensors, you wouldn't feel the pain, right? But if you didn't have a brain to interpret the pain sensors, you wouldn't have pain either. And we also know that people that are born without a pain system called congenital indifference to pain actually die at around age 10 or 11 years old because they can't protect themselves. So remember, pain is a gift. It protects you, keeps you alive. People that are paraplegic, as you know, have skin breakdown because they can't protect their skin. But yeah, pain is a gift. Incredibly delicate, incredibly balanced, and your nervous system's interpreting every bit of it every second. And yeah, if you're in a bad mood or tired or haven't slept, it's going to change your body chemistry. It's going to change your perception of the pain. You're not sleeping, it's also going to change your coping skills. So it's just all a complex process.
Very true. And one last question, Tina just typed in, can hypnosis help?
I'll go back to the same concept that everything works a little bit in chronic pain, nothing works in isolation. So better sleep could be 20%, good physical condition could be 15, 20%, stress management could be 20, 30%. Hypnosis is one of those things that absolutely can help. And the key issue with all these treatments is understand that if it helps 10, 15, 20%, fantastic. It's part of the solution. If it doesn't help at all, don't do it. Some people get a dramatic response from hypnosis. They think, oh, I solved my problem. Well, guess what? If you don't deal with the triggers and the stresses in your life, it's probably not going to be permanent. But just look at the whole thing as a dynamic process. But hypnosis is actually one of the classic ways of actually decrease the body's stress chemicals. But the problem is you can't stay hypnotized your entire life, right? So yeah, if you could, I mean, I was telling my wife yesterday, I think if everybody in this world could be on Xanax or Valium, we'd have real peace, right? They work. And so it calms down the nervous system and you're fine. So the reason why those drugs work so well is they actually work. They actually decrease the stress chemicals. They block the receptors. They fill your body through these GABA drugs. The reason why Valium and Xanax are so addicting isn't because they're addicting like opioids. They actually work. The problem is you can't come off of it. You do build up a tolerance, and there's obviously a downside to do that. So I'm saying that tongue in cheek, but the bottom line is whatever you can do to decrease your body's stress chemicals, and you may need an anti-anxiety drug for a few months to actually get things started. I have no problem with that either. You know, when I was doing this by myself in Sun Valley, I would use Xanax a lot on my patients to start things out. But yeah, in this day and age, maybe CBT might be the answer to Xanax, which may be actually a little bit safer than Xanax. So the CBD drugs could be helpful.
Very cool. David, this has been beyond enlightening, and I know anybody who watches this on the replay is just going to go, their head's going to explode, which is going to be good.
Right.
And anything that we can do to help de-stress people, if a head explosion helps you de-stress, that's awesome. But
right.
I am so grateful that you were willing to come on and talk to everybody, and I will start sending you the feedback from not only the people who are here, but when we start getting it, and I know you're on the page too, so feel free to check out and see what people think. All right.
Yeah, and going forward, it might be fun to get a consensus from the group about the concepts are really different. Again, the bottom line is your anxiety is just simply a measure of your stress chemicals. But once you start putting that paradigm into play, life actually starts to change pretty dramatically. So over the next little bit, just people asking questions to get more of a focused discussion. I'd love to come back and talk to the group again.
All right, that'd be awesome. I appreciate it. Well, thank you very much. I'm going to let you go. Everybody, thanks for joining us. And until next time, take care.
Thank you.
All righty. Bye-bye.
Bye.